Good afternoon, ladies and gentlemen. Today we should speak about injury of the vision organ. To tell the truth, I would like to say you that this is a very important topic. Injury of the eye usually affect young people, and injury is one of the greatest cause of blindness and visual disability. I recommend you to listen these lectures carefully because this information will help you in your future work. If you would like to be ophthalmologist, for example, and if you would like to be ophthalmologist, and if you will be GP or other doctors, the knowing of the basic things, how to diagnose and how to management injury of the eye is very important for all doctors. Injury of the eye and its surrounding tissues is the most common cause of attendance at an eye hospital emergency department. Outcomes of ocular traumas may be the minor or severe with a lot of vision or even the eye. And just to think about mm, these numbers, more than half of the million blinding injuries occur every year. So half of the million people every year mm, become blind because of the eye injuries. Ocular and orbit injuries in the majority of cases occur following sporting, domestic, or motor vehicle accidents. Games and sport are the most common reason of ocular and orbital traumas in children. You see, classification of the ocular trauma, we divided all traumas on local, when just eye and ocular adnexa are affected, or and associated when had also affected face injury, multiply injury like polytrauma. All over the world, where we speak about eye trauma, we use Birmingham eye trauma terminology system. We use this classification. It's rather easy, maybe not so easy, but it helps us to make correct diagnosis and the correct management of the trauma. So, all eye injury we divide it on closed globe and open globe. Closed globe contusion and lamella laceration. Look on this picture. As for the open globe, we divide it on laceration and rupture. For example, in a severe contusion, maybe the rupture of the eyeball. As for the laceration, we divided these these traumas on penetrating, when uh, one um, one part of the eyeball is affected intraocularly, ocular foreign body, and perforating, when we see two holes. As for penetrating, one hole. As for perforating, two holes. Again, on this picture, you see the Birmingham Eye Trauma Terminology System classification, and we will speak about all these traumas. We start from the closed globe injury. The eye wall does not have a full thickness wound. Either there is no corneal or scleral wound at all, contusion, or it's only partial thickness, lamellar laceration. No, for example, for the closed globe injury, extraocular foreign body, for example, cornea, foreign body, abrasion, burns, chemical injuries, closed globe injury with lamellar laceration. As for the cornea foreign body, it's rather often situation, and a lot of the patients come to emergency ophthalmological department with such traumas. We should, if we see um, such situation, we should immediately remove this foreign body, or the patient in future can have severe keratitis or even corneal ulcer. Open globe injury, full thickness wound of the cornea of a sclera, maybe the rupture or laceration. Here you see example with the open globe injuries, the injury of the cornea, and here you see the two iris in this wound, very severe trauma. Uh, okay, speak a bit open globe injury rupture. Rupture is a full thickness wound of the eyeball caused by a blunt object. The impact results in momentary increase of the intraocular pressure. The eyeball gives way at its weakness point, at the impact site or elsewhere. Example, an old cataract um, wound, uh, even though the impact occurred elsewhere. The actual wound is produced by an inside-out mechanism. Okay, more often we see open globe injuries, laceration. Full thickness wound of the eyeball usually caused by a sharp object, like needle, knife, scissors, or flying metallic foreign bodies. The wound occurs at the impact site by an outside-in mechanism. As I have already mentioned, all lacerations we can divide on penetrating injury, uh, intraocular foreign body, and perforating injury. As for penetrating injury, we see single laceration of the eye wall, and no exit wound has occurred. So just one wound. No intraocular foreign body, it's clear. Uh, when we find intraocular foreign body, it's of course open globe injury. And perforated injury, when we see two full thickness laceration, we see entrance and exit. Okay, on this picture you see examples. Okay, penetrating injury, just one full thickness wound. Intraocular foreign body and perforating injuries. You can see entrance and exit. Okay, let's speak about closed globe injury. Clinical manifestation. Let's start from the orbit. Yeah? Blowout fracture, orbital hematoma, carotid cavernous fistula, and also foreign bodies. On this picture, you can see examples of mm, fractures of the orbit. Medial, lateral, blow fracture of orbital floor. Eyelids. Um, when we see the contusion of the eyelids, we can see enormous swelling and um, edematosis, hematoma, avulsion of the lower lid, and foreign body. I would like to say that I hope you remember that eyelids have very good blood supply. That's why hematoma appear very often of the eyelids, but it's also very quickly disappeared. Let's go further deeper. You see conjunctiva. On this picture, you can see conjunctiva hemorrhage. Here you see conjunctival laceration and you see conjunctival foreign bodies. It's also closed globe injuries. Cornea. Uh, I have already mentioned that maybe abrasion, stromal edema of the cornea, partial rupture, blood stain of the cornea when cornea, blood enter into the cornea, and cornea foreign body here. Look on this picture. You can see the corneal foreign body. On this picture, you again see the corneal foreign body in a microscope. On this picture, you can see how we remove foreign body. It's an outpatient procedure. We make this in an emergency department. I have already mentioned that it's absolutely necessary to remove corneal foreign body. Usually we put anesthetic drops like alkaline, for example, and then remove foreign body. Cornea is very sensitive, but cornea reacts very good on local anesthetic. And when you put alkaline, for example, you can remove foreign body without any difficulties. Okay, go deeper, go further. We decided changes in cornea, then go deeper, anterior chamber. Mm, Rather often in a closed globe injury, we can see hyphema or changes of the deepness of anterior chamber. On these examples, you see on this picture, you can see different examples of hyphema. Mm, As for anterior uvea, pathology of the iris, We can see iridodialis. Yeah. We can see tear of the iris sphincter, iridoschesis, and angle recession. Okay, let's go further, deeper in the structure of the eye. Then after iris, lens. We can see Wilson ring. We can see cataract. What is cataract? Any opacity of the lens. And we can see subluxation or luxation of the lens, so we can see the changes in the lens position. Lens can move forward or in a vitreous body. Vitreous body after the lens, I hope you remember anatomy. We can see posterior vitreous detachment. It's not so serious situation, but in severe cases, in severe contusion, we can see the hemorrhage in the vitreous. Uh, you know that blood is not transparent, and that's why hemorrhage in vitreous rather serious situation because patient complains on bad vision. Retina, the most important part of the eye, it's a mm, sensitive part of the eye, and we can see different changes. Of course, hemorrhages, you can see Berlin's edema, macular edema, and you can see even retinal dialysis or even retinal detachment. Optic nerve. When we examine the fundus of the eye, we can see the disc of the optic nerve, and we can see traumatic optic neuropathy like edema of the optic nerve, hemorrhages, and in very severe traumas, we can see avulsion of the optic nerve. Okay, another example of open close injury are burns. Burns are the very important cause of visual disability. Mm, the most important burns, chemical, thermal, and UV burns. As for the chemical burns, we can divide all burns on alkaline and acid. Chemical burns are more severe, and severity of the eye burns depends on the agent, its concentration, and duration of exposure. Usually, we say that alkaline burns mm, is severe than acid burns because alkaline mm, usually spreads and tissue more quickly than acid. Alkaline makes colliquative necrosis and acid coagulating necrosis. I hope you remember this from the course of pathophysiology. Uh, Clinical features of the eye burn, I think it's easy to predict. Usually, it's very great pain. The patient can't open the eye, tearing, blepharospasm, mm, decrease of or loss of vision. You can, during examination, see the edema, redness of the eyelids, of the conjunctiva, the severity uh, of eye burn. Usually, we measure by Roper Hall classification. According to this classification, we have four grades of the burns. First grade, we see epithelial damage, no limbal ischemia, and such burns usually have good prognosis. Grade second, hazy cornea, iris detail visible, and limbal ischemia less than 1/3, and other mm, uh, the prognosis is also good. Great. Third, cornea is opaque, iris we can see, mm, and limbal ischemia near half, and visual prognosis usually not so good. And grade 4, um, very severe, um, very severe burn, uh, totally opaque cornea, limbal ischemia more than half of the limbus, and prognosis usually poor. But on this um, picture, you see examples of um, examples of burns. This is the first grade. This is second. You can see limbal ischemia, and this is the third grade. Uh, well, let's speak about treatment of chemical burns, the most important first aid. If you will be ophthalmologist or not, you should know how to help the people with the chemical burns. Very important prophylactic of shock, local and systemic um, anesthetic, analgesic and anesthetic. If we see the pieces of chemical structure, we should remove these pieces, and then we should irrigate and we should wash the eye as much as possible to remove um, the pathological structures, pathological agent very carefully. Usually we use water or saline solution near 5 minutes. Then we should put antiseptic and antibiotic in eye, and also um, give to the patient systemic antibacterial medicines. We should prescribe tetanus prophylactic, ointment, uh, antibacterial or antibiotic ointment, and the skin usually treated with different sprays like panthenol, different antibacterial ointment. Very severe complications maybe after chemical burns. Usually these are corneal opacity, symblepharon, recurrent corneal ulceration, complicated cataract, and secondary glaucoma. Look, the total opaque cornea. This is also against cornea. We see that conjunctiva close the cornea defects. Here we see that very severe, after very severe burn, we have totally closed eyelids. Thermal injuries, usually caused by fire or hot fluids. Usually the mm, the conjunctiva and eyelids suffer more severe from this thermal burn than cornea and more deep structure. The usually the first aid is same like in the case of the chemical burns, but there is no necessary to wash the eye so long time. I think it's necessary to wash just to decrease the temperature, but not so long as in the case of chemical burns. And all other procedure uh, are the same like in the case of chemical burn. So we should prescribe analgesic, we should prescribe antibiotic, local and systemic, we should prescribe tetanus prophylactic, and of course we should send the patient in an ophthalmological department. Ultraviolet burns usually etiology of the situation, welding without proper eye protection, exposure to high altitude sunlight, and sunlight reflected off snow when skiing, and sometimes we also can see the patient or a nurse who work in the hospital and use correct oil lamp. Symptoms usually very typical. The process, the um, symptoms usually appear after 6 or 8 hours, and the patient complains on pain, bad vision, feeling of foreign body, lacrimation, so the typical corneal syndrome. Examination. During examination we can see redness of the eye, we can see corneal edema, and superficial puncture keratitis. Uh, Treatment. The blinded patient should be instructed that the symptoms will resolve completely under the treatment with antibiotic ointment within 1 2 days. Mm, and usually we use intramuscular analgesic and can put anesthetic drop in conjunctival cavity. The prognosis usually good, and the patient should be instructed to use special glasses when he works with the UV devices. So we have already discussed closed globe injury. Now we should speak about penetrating injuries. On this picture, you can see examples of severe penetration injuries when we see the full laceration of the cornea. So, absolute signs of penetrating wound: gaping wound in the eye, protrusion of the eye bone contents outward. For example, here you see protrusion of the iris and the presence of intraocular foreign body. In some cases, when we see the small injuries, for example, in cornea, we can't say exactly is it penetrating or not. We use fluorescein, which help us to say is it penetrating eye wound or not. Not. We see that this is penetrating eye wound. I would like to show you some examples of penetrating eye wound. Look, this is a severe cornea injury, iris, eye wound, scleral eye wound. This is a intraocular foreign body. This is intraocular foreign body in the fundus of the eye. I would like to tell you that all foreign body which are situated in eyeball have to be removed. If we say foreign body in eye, we will receive the severe complication like different metalloses. We will speak about these complications a bit later. And how we diagnose the foreign body in eye. Of course, we can use slit lamp. It's a biomicroscope. You will see such devices during our practical classes. We can use X-ray. It's one of the most important method, and ultra and we can see um, ultrasonography, also a very informative method. What should we do if we see the penetrative wound of the cornea? First aid, it's very important. We can uh, we can, uh, at first we should make the patient medicine for the shock prophylactics like local and systemic analgesics. We should remember of the tetanus prophylactic and about infection prophylactic. So we should put local antibiotic and systemic antibiotic, and we should make binocular bandage. So we should close both eyes. You should ask me why, if one eye is affected, we should close both eyes. It's important because when one eye is moving, other eye also moves. So we should close both eyes to prevent additional trauma. The first aid in a case of penetrative wound of the sclera is the same like in a case of penetrating wound of the cornea, but we also should add the medicine which help us to prophylact hemorrhages. In a special ophthalmological department, of course, we should make the surgical operation to to prevent difficult complication and the purpose, of course, of our treatment to save eye's anatomical structure, and if it's possible, to save visual function. In very severe cases, when we see the crushing of the eye wound, of the eyeball, we make enucleation of the eye. What are indication for enucleation of the wounded eye? Primary enucleation is performed in the case of crushing of the eyeball, and later eye is enucleated in the case of recurrent sympathetic inflammation of the healthy eye, painful secondary glaucoma, and atrophy of the eyeball. Let's speak about complication of the perforative and penetrating eye injuries. Of course, it's infection, maybe purulent iridocyclitis, endophthalmitis, panophthalmitis. I would like to say that even small trauma, penetrating trauma, with a good visual function may be the cause after 1 2 days of severe endophthalmitis. Oh, it's a pity I saw several such cases. Uh, when we leave intraocular foreign body in eye, we can see complication like metallosis or siderosis and halcosis. In later time, we can see sympathetic ophthalmitis, traumatic cataract, secondary glaucoma, and retinal detachment. Let's pick some words about metallosis. Halcosis appear when the copper foreign body uh, is in eye. We see cornea in cornea Kaiser-Fisher ring, a golden round ring at the level of the cement membrane. We can see anterior sunflower cataract. We can see green discoloration of the iris, so our iris becomes green, and we can see yellow retinal flages. Uh, Siderosis appear when we don't remove ferrous foreign body. Siderosis may develop as early as a few days or as late as several years after injury. Clinical features include redness, mm, heterochromia of the iris, secondary glaucoma, anterior capsular cataract, also reddish ferrous deposits, and we can see pigment dispersion and retinal detachment on the retina. Some words about very severe complication of the penetrating eye wound, sympathetic ophthalmitis. This is a condition in which granulomatosis uveitis attacks the second eye after the injury of the eye. So this is inflammation of the healthy, normal eye. And you can imagine how difficult and how serious situation. We have on one eye uh, with a bad vision after the trauma, and after 2 3 months or even years, another healthy eyes becomes mm, becomes ill, becomes sick. Usually, the time of interval between injury and development of sympathetic ophthalmia 3-8 weeks. In rare cases, 5 days or even 60 years after penetrated trauma. And the cause this um, of this situation of this process antigen antibody interaction. Nowadays, thank goodness, we rarely see such situation. It's the prophylactic of this situation as a good surgical treatment um, of the trauma using steroids and other modern medicines. And clinical picture of sympathetic ophthalmitis. As for injured eye, low-grade plastic uveitis, which include ciliary congestion, lacrimation, and tenderness. And second eye, sympathizing eye, normal eye, which was normal. We see acute plastic erythritis. Treatment of sympathetic inflammation is very difficult. We should make enucleation of the injured eye. We should use anti-inflammatory, serious, aggressive anti-inflammatory treatment like using the topical and systemic steroid. In severe cases, immunosuppressive drugs. And no, of course, atropine to prevent synechia and other plastic processes. I would like to thank you for your attention. I hope you will receive some necessary information for you how to manage the eye injuries because early diagnostic and first aid are the most important things for good visual prognosis in eye traumas. Hope to see you in our practical classes. Good luck and thank you for your attention. Good afternoon, dear students. We continue our ophthalmological lectures. My name is Anna Kapayenko. I'm a professor of ophthalmological department. Today's topic is inflammatory diseases of the eye. We start from the inflammatory disease of the conjunctivitis. 80% of all patients who come to ophthalmologists have conjunctivitis. So it's rather often disease for young patients, for children, and for elderly patients also. Symptoms are very simple: redness of the eye, irritation, and discharge. As for objective signs, usually during examination of the patient, we can see conjunctival hyperemia or redness of the eye and different discharge. Discharge may be watery, mucoid, purulent, and the type of discharge can help us to suggest the the type of conjunctivitis, viral, bacterial, allergic, or other cause of conjunctivitis. We should speak a little bit about classification of conjunctivitis. Infective conjunctivitis are bacterial, chlamydial, viral, fungal, protozoal, parasitic. A big group allergic conjunctivitis. I would like to say that nowadays more and more patients suffer from allergic conjunctivitis because of our ecological situation, because of our unhealthy food, and so on. Next group, irritative conjunctivitis. Keratoconjunctivitis associated with diseases of skin and mucous membranes, traumatic conjunctivitis, and keratoconjunctivitis of unknown etiology. I would like to show you some picture. Look, this is a typical picture for chlamydial conjunctivitis. You can see redness of the conjunctiva of the upper lid, edema of this conjunctiva. Here is gonococcal conjunctivitis, a lot of pus in eye. Here, bacterial conjunctivitis and viral conjunctivitis, mucus or mucowatering discharge. As for diagnostic of conjunctivitis, it's not so difficult, and we should speak a little bit about the treatment of acute bacterial conjunctivitis, rather often disease as for the children as for the adult patient. Of course, at first we should prescribe antibiotics, topical antibiotics, wide spectrum. It may be ciprofloxacin, tobramycin, ofloxacin. We should prescribe these antibiotic drops rather often, 6, even 4 times per day. Before prescription of antibiotics drops, we should take samples from conjunctiva, and we should send the samples to laboratory, and this laboratory will give us the answer what is the cause of this bacterial conjunctivitis. But we receive this answer after 2-3 days. That's why we take samples and prescribe wide spectrum antibiotic. And we ask to the patient to come for the check-up after 3 days. We will see the clinical picture of this patient, and we will receive the result from laboratory. And if the patient feels better and we see the answer from laboratory that bacteria is has sensitivity to this antibiotic, we can continue this antibiotic. If not, we should change antibiotic drops. In the case of acute bacterial conjunctivitis, we don't recommend the patient bandage. We shouldn't prescribe steroids, and we can prescribe non-steroids anti-inflammatory drugs, but systemically. Usually it's orally tablets we can prescribe. Treatment of viral conjunctivitis, we shouldn't prescribe antibiotics. We can prescribe topical antiseptic like Vitabact, for example, for 8 times per day, and we can prescribe a topical antiviral gel, for example, ganciclovir Virgan, 4 times per day. Also, no bandage, no steroids, and we can prescribe in the case of great inflammatory process, irritation, we can prescribe non-steroid anti-inflammatory drugs systemically. Now we should discuss the inflammatory diseases of the cornea. This is part of the fibrosis layer. Normal cornea are vascular, sensitive, transparent, smooth, glassy, spherical. inflammation of the cornea we call keratitis. If you see any obesities on the cornea, if you can see lesion on the cornea, infiltration of the cornea, we can think about keratitis. Objective sites of the keratitis: corneal edema, cellular infiltration, and ciliary congestion. When we say about conjunctival reaction, you should remember this chart. On this picture, you see unchanged portion of the eyeball. On this chart, on this picture, you can see conjunctival or superficial redness of the eye. On this chart, you can see pericorneal hyperemia of the eye or ciliary congestion. And on this part of the picture, you can see mixed injection of the eyeball. As for when we speak about redness in the case of conjunctivitis, it's a superficial redness. When we speak about keratitis, usually it's pericorneal or mixed hyperemia or injection. Okay, we have already mentioned the objective signs of keratitis, and now we should speak about complaints of the patient. A patient usually complains on photophobia. Photophobia, it's when the patient can't see on the light. Lacrimation or tearing, blepharospasm when the patient can't open their eye, sensation of the foreign body, and pain. You will see in your textbook and in a specific ophthalmological literature the words corneal syndrome. So corneal syndrome, it's a syndrome which is characterized all types of keratitis. And corneal syndrome includes patient complaints and objective signs. Classification of keratitis. All keratitis, we can divide it on exogenous keratitis, endogenous keratitis, and keratitis of unclear etiology. Exogenous keratitis, when bacterial agent or other agent comes to eye from outside. And endogenous keratitis is a situation when pathological agent comes to eye from the patient body. So, as for exogenous keratitis, we can divide all these keratitis on corneal erosion, traumatic keratitis, microbial keratitis, keratitis caused by diseases of conjunctiva, eyelids, fungal keratitis, corneal ulcer. Endogenous keratitis may be infection like tuberculosis or viral, rheumatic, neuroparalytic, keratitis because of avitaminosis. When we see the patient with keratitis, we can make a great investigation of such patient. We should try to find the the cause of this keratitis. That's why we should make X-ray of nasal sinuses and the organ of the chest. We should send such patient for, for the check-up to the ENT doctor and dentist and make routine laboratory tests. Of course, we should try to find the cause I have already mentioned, infection agent, and we should make samples from conjunctival sac to try to find the cause. Is it viral or bacterial? Principles of keratitis treatment. Of course, if we know the etiology, etiological therapy. Or we should prescribe non-steroids anti-inflammatory medicines like inhibitors of proteases, prostaglandins, and uh, other biologically active substances. We should prescribe mydriatic solution like atropine or tropicamide. We should prescribe the drops which improve epithelialization of the cornea, like corneal gel, actovegin, sulcoceril, immunomodulators, antihistamine drugs. Also, we can prescribe the general therapy which improve nutrition, like vitamins. In severe cases, we can prescribe surgical therapy, surgical method. Usually, we use this method in a case of scars on the cornea after severe keratitis. We can prescribe the corneal transplantation, keratoplasty in a case of severe cornea opacity. Some words about bacterial keratitis. Bacterial keratitis often develop in chronic inflammatory diseases of conjunctiva and lacrimal ducts, as well in a case of the trauma of the cornea. The risk factors for bacterial keratitis: contact lens wearing, non-surgical trauma, in some cases surgical trauma, corneal injury caused by lid dysfunction, corneal conjunctival or lacrimal dysfunction also may be the cause of bacterial keratitis. Treatment of bacterial keratitis, I have already mentioned that we have to take the samples from the cornea to determine the pathological agent. We should dilate the pupil by installation of tropicamide, and we should prescribe antibiotics drops, new wide spectrum antibiotics like tobramycin, levofloxacin, moxifloxacin, 6-8 times per day. In severe cases, we also prescribe antibiotic injection in subconjunctival. Look at this picture. I'm sorry. You can see these examples of severe keratitis. You can see even keratitis with necrosis. Here you can see the example of tuberculosis keratitis. For the tuberculosis keratitis, very typical clinical picture. You can see phlectena and you can see neovascularization to this area. Rather often, we as an ophthalmologist see the herpes simplex keratitis, maybe primary or secondary herpes simplex keratitis. Primary ocular infection typically occur in children between the age of 6 months and 5 years. This is rather severe situation, and this process is rather frequently accompanied by enteral uveitis, keratic precipitatus, early vascularization, hypoanesthesia, photophobia, blepharospasm, and lacrimation. Recurrent herpes simplex infection we can divide on epithelial puncture keratitis, dendritic keratitis, metaherpetic keratitis, and disciform keratitis. On this picture, you can see the specific picture of dendritic keratitis. The picture on cornea is very typical, and we even don't need special laboratory diagnostic to say, oh, this is herpes viral keratitis. And clinical picture in these cases is help us to make a correct diagnosis and to prescribe treatment. Patients with a herpes viral keratitis usually complains on photophobia, lacrimation, pericorneal hyperemia, and hypoesthesia. Look on this picture. This you see dendritic keratitis. This is like outcomes of dendritic keratitis. You see opacities on the cornea, but here you can see severe, deep, distinform keratitis, herpes viral keratitis, very severe situation, very bad visual acuity, and this is rather dangerous situation. Here you again on this picture, you can see dendritic keratitis. Okay, as for the treatment of herpes simplex keratitis, we have a specific local treatment antiviral substances. It may be acyclovir or company name Zavirax, 3% ointment 5 times per day. Or we can prescribe ganciclovir Vilgan or 0.50% eye gel also 5 times per day. This is local treatment. It's a specific antiviral treatment. Also, we should add systemically antiviral treatment. Usually we use tablets. It may be valacyclovir or Valtrex. Tablets 500 milligram 2 times per day. Or acyclovir Zavirax 200 milligram 5 times per day. Also, we should prescribe metabolic therapy like coronary gel or tofu 3-4 times per day. Immunomodulating systemic therapy is indicated in a long severe um, cause of frequent recurrences. And deep form of keratitis rather often mm, may be the cause of eye hypertension. And in this case, we prescribe hypertensive therapy. In severe recurrence cases, we can prescribe cryotherapy. It's like a surgical procedure. We go further. We have already discussed bacterial, viral keratitis, and now we should speak about keratomycosis. Risk factors of keratomycosis: long treatment with the antibiotic or corticosteroids. The next risk factors: micro traumas of the cornea, fungal skin diseases. Signs of keratomycosis: grayish white infiltrate with yellowish border. Hypopyon is also typical, and vascularization. Treatment of keratomycosis. Locally it's a ketoconazole, miconazole ointment 4 times per day. Also, we can wash conjunctival sac with solution of boric acid. Systemically, we can prescribe Nizoral 200 milligram 2 times a day, or other anti-mycosis substance. We can add anti-allergic and anti-inflammatory eye drop. In severe cases, we can add paraocular dexamethasone, corticosteroids, uh, just uh, just 0.3 millimeters, because corticosteroids we couldn't prescribe very often, because corticosteroids can improve the growth of mm, fungal agents. Severe keratitis, deep keratitis, we call the ulcer of the cornea. Ulcer of the cornea is the inflammation of the cornea membrane, accompanying with necrosis with formation of the tissue defect. Infection may be bacterial, herpes, viral, fungal. Non-infection are immune diseases, corneal cirrhosis, and in a severe absolute glaucoma, in the case of very high intraocular pressure, may be also cornea ulcer. Risk factors: conjunctivitis, ductal cystitis, corneal sclerosis, traumas of the cornea, foreign body of the cornea, which um, didn't remove at time, injuries by chemical, thermal radiation, laser affection, long wearing of contact lenses, operation of the cornea, and bullous keratopathia. There are some stages of ulcerosis process in the cornea: stage of infiltration, stage of infiltrate decay and ulcer formation, Stage of facet regression of ulcer, growth of epithelium that covers the fundus of the margins of the cornea defect. Stage of the scar formation. Stage of outcome, maturation and thickness of the connective tissue scar. This is a good way of ulcerosis process, but in severe cases, cornea becomes thinner and thinner, and here you see the full defect of the cornea perforation. You can see the hole in the cornea. It's a very severe situation, uh, and in this case, we mm, we should make keratoplasty immediately to close this defect. Principles of the treatment in infectious corneal ulcer. Also, we can, in better cases, we should know the cause of the ulcer and prescribe specific antiviral, antibacterial, antifungal, or antiparasitic treatment. Also, we should add metabolic, anti-inflammatory, anti-allergic, and immunomodulated hypertensive drugs. If we know that the cause of the ulcer is bacterial infection, we should prescribe antibacterial therapy, like in a case of keratitis, but we should prescribe more strong antibiotics more often. We can prescribe some conjunctival or paraocular injections of antibiotic by spectrum nowadays antibiotics. Also, we should prescribe this antibiotic systemically, like doxycycline, cefazolin, moxifloxacin. We should add anti-allergic and anti-inflammatory drops like Nacluf or Patanol. And in a stage of regression, we should add metabolic therapy which improve epithelialization like corneal gel, Taufon, Vitasic. So we have already finished with the inflammatory diseases of the cornea. We have already discussed the most important cornea inflammatory diseases. You can also read more deeper in your textbooks, and we go further, and we should discuss the inflammatory diseases of the sclera. Sclera is here is a cornea, yeah? And here white structure is a sclera. Episcleritis is the inflammatory disorders of the superficial layers of the sclera. It's self-limiting and frequently recurrent disorder of which typically affects young adults. The episcleritis may be nodular or diffuse. Episcleritis rather often is associated with collagen diseases, herpes zoster, syphilis, erythema nodosum, and other systemic diseases. Usually, episcleritis presents in young adult, and patient usually complains on severe pain, which is localized in the eye. The inflammatory process does not involve underlying sclera, and intraorbital tissue. Episcleritis usually resolves spontaneously after 3 weeks, but may recover. Now, on this picture, you can see nodular episcleritis and diffuse episcleritis. No discharge, redness localized in a specific area, cornea is clear. In such cases, you can think about episcleritis. Episcleritis treatment, usually we use steroids, local steroids, for example, solution of dexamethasone, 0.1%, 5 times per day. Also, you can add orally or intramuscular non-steroids anti-inflammatory medicines. Usually, it's necessary to add non-steroids anti-inflammatory medicines for reduce pain and inflammation. Scleritis, it's a deeper inflammation that episcleritis. Scleritis is granulomatosis, inflammation of the sclera. Usually scleritis associated with systemic diseases like rheumatoid arthritis, ankylosing spondylitis, rheumatoid diseases, Wegener's granulomatosis, or infection like herpes zoster, syphilis, tuberculosis. So if you see the patient with episcleritis or scleritis, you should make the systemic checkup of this patient, to send this patient um, for special investigation. Scleritis may be anterior, posterior, not necrotizing or necrotizing, diffuse or nodular. On this picture, you can see the examples of scleritis. Patient usually complains on severe boring ocular pain that radiates to the temple, jaw, or sinuses. Very severe condition of the patient. As for the treatment of scleritis, we should prescribe locally steroids, of course, systemically non-steroid anti-inflammatory medicine, but also in severe case we should use systemically steroids and try to treat the cause, systemic disease, which is the cause of scleritis. Okay, already finished with diseases of the external fibrosis layer, cornea and sclera. Now we should discuss the inflammation of the second layer of the eye or vascular layer. The inflammation of the vascular layer of the eye we call uveitis. Rather often disease, rather severe disease, and it's necessary to know how to diagnose and how to manage such situation. According to anatomy, we can divide uveitis on anterior uveitis. In this case, inflammatory process is affect iris and ciliary body. Intermediate uveitis affect ciliary body and pars planum. Posterior uveitis affect choroid and retina. You can say, oh, retina, it's not a middle layer, it's a third layer, it's internal layer. But choroid and retina have very good connection. And to tell the truth, we never have just retinitis or choroiditis. Usually we see choroidoretinitis. And panuveitis, inflammation of all part of the uveitis, choroid, ciliary body, and iris. Clinical classification of the uveitis: acute uveitis, which lasts less than 3 weeks, and chronic, which last more than 6 weeks. Etiological classification of uveitis: we can divide all uveitis on exogenous and endogenous. So, exogenous, when pathological agent comes from outside, usually it's a traumas, traumas or surgical trauma, so after operation. And endogenous uveitis is caused by microorganism or other agent from the patient's body. Now we will speak about endogenous uveitis, because exogenous uveitis we will discuss during the traumas. So endogenous uveitis may be associated with systemic diseases, infection, idiopathic. Pathological classification: uveitis may be granulomatosis or non-granulomatosis. Now we should speak about anterior uveitis. As for anterior, the patient usually complains on pain, photophobia, lacrimation, blepharospasm, blurred of vision, and redness. Signs, objective signs: we can see ciliary injection or pericorneal hyperemia, or in some cases mixed hyperemia. We can see meiosis of the pupil or irregularity of the pupil. We can see band keratopathy, corneal injection, or corneal edema, and keratic precipitates. Look at this picture, you can see keratic precipitates on the endothelium of the cornea. In anterior chamber, we can see flare. In severe cases, hypopyon. On this picture, you can see synechia. It's a connection between iris and anterior capsule of the lens. Or we can see loss of normal pattern of the iris, changes in iris color, and iris nodules. In the case of posterior uveitis, you have absolutely other complaints. If the patient, you remember, if the patient with anterior uveitis complains on pain, redness, discomfort, and so on. As for the posterior uveitis, no redness, no pain. It's appear because of choroid doesn't have sensitive innervation, so no pain. No. And the patient usually complains on defective vision, photopsia, black spot in front of the eye. During examination, we can see positive scotoma. And the most important, we, during examination using the ophthalmoscopy or slit lamp ophthalmoscopy, we can see the lesion of the fundus of the eye. And the complaints of the patient depends uh, on this lesion. Where is this lesion situated? If in the center of the retina, the patient has a lot of complaints on bad vision. If it's in periphery, the patient uh, in some cases doesn't have any complaints. The treatment of uveitis. Usually the aims of the treating uveitis are to prevent vision-threatening complication, to relieve the patient discomfort, if possible, to treat the cause of the uveitis. The four groups of medicine usually used in the uveitis treatment: mydriatics, steroids, cytotoxic drug, and immunosuppressive drug. And if we know the cause, we should treat we should use the antimicrobial or antiviral agent. Now, I would like to tell you about severe diseases of the orbit. I told you that our lecture will be inflammatory diseases of the eye, but I would like to tell you also some words about cellulitis, inflammation of the orbit. It's a severe condition, and this condition is dangerous not for eye, not for visual acuity, but also for the patient life. The risk factors of orbital cellulitis. At first, it's a sinus diseases, mm, infection of the other structures on the face, facial infection, ductal cystitis, dental abscess, trauma, and in the case of surgical trauma, orbital lacrimal and vitreoretinal surgery may be the cause of the mm, orbital cellulitis. In the picture, you can examples: exophthalmos, lid, eyelids, hyperemia, edema, severe edema. As for the symptoms and signs of orbital cellulitis, patient complains of headache, fever, pain, nausea. During examination, we see that eyelids are swollen, erythematosis, red, or warm and tender to palpation. We can see chemosis of conjunctiva. Ocular movements are restricted and painful. In advanced cases, visual acuity may be very low. I have already mentioned that orbital cellulitis is dangerous for the patient, and we can see the intracranial complication like meningitis, brain abscess, and cavernosus sinus thrombosis. Periorbital abscess also we can see in a case of orbital cellulitis, and ocular complication, keratopathy, in rise intraocular pressure, high intraocular pressure, occlusion of the central retina artery or vein, optical neuritis. The treatment of the orbital cellulitis should be aggressive. Of course, it's hospitalization, intensive antibiotic therapy, mm, retrobulbar injection, intravenous antibiotics, analgesic and anti-inflammatory drugs, osmotherapy. And when we see the mm, patient with orbital cellulitis, it is necessary to surgical treatment. It's necessary to make surgical drainage. And of course, we should send such patient to INT doctor, to dentist, to find the cause of this disease. And we should treat such patient together with the other specialist. If we make drainage of the orbit, but our colleagues INT doctors don't make drainage from the sinuses, our treatment will be not effective. So be careful with such patient if you see or if you suggest orbital cellulitis, you should react immediately. I would like to say you thank you for your attention. Hope to see you in practical classes, during our practical classes, and during our future lectures. See you and thank you for your attention.